Thank you, Nitya, for this, and it's a pleasure to be here today. I think uh, initially when you sent me the invitation, I was like, what am I going to speak to all the programmers and the statisticians um, regarding in the area of oncology? Um, but I think there is so much that is happening in the fields of oncology as well as biostatistics that I think we need maybe a series of such seminars. And I think I'm glad that you've started this, but I really think that this topic may deserve a full series of seminars to bring variety of people together. There are some journals that have started focusing on this whole area because of sheer volume of work that we are now seeing in oncology specifically. And thank you all. Good morning. And let me walk through a few slides which give a perspective of, or try to give a perspective of what's happening in the oncology space and, more specifically in the clinical research space and what challenges may be, at least from a layman perspective, that I can see in the areas of statistics. The burden is the first thing that I would like to say, starting from the patient, I think, which I would like to say is that, you have enormous increase in the burden of the disease, going to about 24 million in the next 20 years, or maybe next 15 years now. India is no far behind. In fact, India's number of cases will probably double in the next 10 years. And that is enormous in terms of the burden that we are going to see. The number of cancer deaths is also increasing steadily, though the fatality rate has come down. Overall life expectancy has increased across a variety of cancers. And I think if you look at the last 3-4 decades, we can definitely see a significant improvement in both expectancy as well as quality of life for patients. So from a purely a researcher perspective, I think we can all be proud that we have actually saved lives and we have improved the quality of a lot of people. Spend is increasing. This is the treatment spend, and about 170 billion would be estimated to be spent now in 2020, given COVID. I think it's slightly maybe fallen short, but it's still a huge amount of money that is being spent by patients in terms of treatment, diagnostics and treatment, right? And then this is across all therapeutic areas, and 60% of that is in the area of oncology. And there is no difference between this and the increased amount of research. We are all aware that the number of clinical trials or research that is being, studies that are happening across therapeutic areas is increasing, but about 60% of that in oncology, and a significant component of that is coming through oncology. So huge amount of focus in the area of oncology. We know a lot more about the disease, or rather diseases, rather than maybe 10 years ago. And yet, the more we know, it seems like the lesser we seem to know in terms of how to solve the problem. But I think we made significant progress anyways. The one point that is important to also note is that there is increased speed in terms of the way the trials are being run. So the breakthrough therapy designation that was given for experimental drugs by the Food and Drug Administration in 2012 accelerated the review and development process for new therapies. The availability of pre-screened patient tools, biomarker tests is also improving productivity by almost 100% in terms of what we can do now versus what we were able to do just 5 years ago. The average time from the first patient launch was about 18 years in all therapy areas. And in 2018, this number in oncology was 10.5 years. So just to let you know that oncology, there is an enormous amount of speed in the trials that has been written, primarily because of the breakthrough therapy designation, but also some of the efficiencies. And by 2019, we had 47 immunotherapies approved by the US FDA. And just as an example there, just 3 months after the publication of phase 1 data, we had a molecule that was FDA approved. There's also an increased number of next-gen biotherapeutics. So it's not just one type of molecule. It's not just one mechanism of action that we are studying, there is so many different targets and so many different types of drugs that are being researched, that there is enormous complexity that is coming into the area of oncology research. So we know a large number of the oncology complexities were already there. Phase one, phase two designs were very complex, and I think the speakers coming after me will speak to that. There's meta-analysis related issues, genomic data that is coming into the play. The molecular characterization of tumors is the other big thing that has changed, is different from typical other types of therapy area trials. And the clinical trials of targeted therapy is more complex, and I will talk a little bit more about that in the presentation. Also, adaptive designs and surrogate markers. These were known complexities, already known in the area of oncology. But the new challenges that we are seeing is, for example, in the area of CAR T therapy. The fact that cytostatic or targeted agents were already there, and it required a certain level of data analysis or bivariate or trivariate data analysis. But now you need a lot more high dimensional data and imaging techniques that are incorporated because of the type of therapy that we are introducing. Immune checkpoint inhibitors, availability of those, the monoclonal antibodies that we now have, and the CAR T therapy, all resulting into what we call the immunotherapy area, has really shown a lot of impressive clinical activities, but also the toxicity profiles that we see and the mechanisms of action that we see are so different to what we are used to. The classic assumptions that were known are probably no longer applicable. So, for example, monotonicity is no longer a valid assumption. So, immune oncology agents do not always generally impact the malignant sense. The immune cells indirectly facilitate the efficacy of the agents, or the cytotoxic efficacy of the agents. So in combination with the cytotoxic drugs or targeted drugs, you will see a lot more activity. So the way we think about toxicity itself, where acute toxicity was being used as a measure, is not a sufficient representation for the tolerability of immune oncology agents. Also, these are administered over extended periods of time. So how do you measure the adverse events? Are they immune-related adverse events, or are they adverse events resulting from the cytotoxicity of the drugs itself? And the evaluation windows all have to be modified given the fact that these are administered over a significant period of time. So new approaches are definitely required in the dose selection processes. I think there are speakers who are going to talk about this. PK, PD, and immune-based biomarkers are included now in the selection criteria in terms of how do you design the trials, right? Thinking about maximum tolerated dose. I mean, the dose that we would use in a phase 1 study to define what is the maximum tolerated dose, for example, would be in the first cycle, you give the patient a dose and then you assess what is the maximum tolerated dose in a small number of patients. And then you use that typically in the next phase or the next cohort of patients. But because of the types of drugs and the immunotherapy drugs that we are using, the minimum effective dose can be also thought about, right? What is the minimum effective dose, which basically assumes that as you increase the dose, the toxicity will increase. But as you increase the dose, the mechanism of action is increasing, and therefore you're more effective in terms of the way the drug is working. However, as we know, that immunotherapy may not have a similar way of working. Therefore, we cannot anymore use these two as the way to define the dose that is actually going to work. So you've got something called the optimal biologically active dose that has to be defined, which is a safe dose that demonstrates the greatest pharmacological activity. Also, monotherapy is now being replaced with a large number of drug combinations. We know that drug combinations have possible benefits because, if, for example, there could be two drugs that have no overlapping toxicity profiles, but the effectiveness, the efficacy for the patients could be greater. The complexity is, how do you design such trials? How do you plan for such trials in terms of defining the dose, and how do you measure them in terms of the activity, in terms of the response? These present huge amount of challenges, obviously, from a statistical perspective. Phase zero trials have also been talked about, of course. Just we know that patients invariably have advanced cancers. When we are introducing them into clinical trials, they have not responded to other treatments. So they have already been tried and tested in all other treatments. So they are typically, the morbidity may be very high. They already are, fairly exhausted, maybe one could say, in the treatment life cycle. And we expect, however, a 3-month life expectancy, a performance status of 0 to 1, absence of comorbidities, restriction in the use of other medicines, and preserved organic functions, which is a very steep ask from a patient perspective for those who have already gone through a host of prior treatments. And selecting patients within a specific molecular profile is obviously increasingly now applicable, because you've got targeted therapies. And the treatment time is very short because of the progression of the disease. And therefore, and a lot of laboratory and radiological assessments are also frequently required. So from a patient perspective, you can imagine what is happening to the person, right? I mean, they've gone through a large number of treatments, but we are not giving them much promise in terms of life expectancy. There are steep criteria, then there are a large number of radiological and laboratory assessments that require to be done. And so there is obviously a trial to say that, can we do a smaller number of trials on humans to test the specific effect of the molecular targets, so that we reduce the number of patients or subjects, as they call participants now, required in the clinical trials, because of the kind of, say, inconvenience or the lack of benefit that sometimes we can show. So zero phase trials or phase zero trials where have been around, and you study efficacy through pharmacodynamic tests to find the dose of a phase 4 or phase 1 trial. So you do it in a very small number of participants. You use only small number of molecular targets, and these are some of the limitations as well. And biological criteria needs to include the pharmacodynamic response and EBD. The short period of time in which the drug is administered may not offer any benefit to the patient and may still cause adverse events, right? Because of the trial that we're going through. So those are the limitations in phase 0 trials. So we need to be cognizant of this when we are designing studies in oncology, which is quite different to the other therapy areas. So new statistical approaches are required. We need to probably look at the extension of the dose limiting treatment evaluation window. These are typically multidimensional. Many of you statisticians in the room are more familiar with this. Bivariate continual reassessment for toxicity and the measure of efficacy is required. And sometimes trivariate, where you have these three aspects to be evaluated, whether there is no efficacy and no maximum tolerable dose, or efficacy without maximum tolerable dose and severe maximum tolerable dose, making efficacy irrelevant. So there are newer techniques as well, like tight CRM, which is time to evaluate, event continual reassessment, as well as Bayesian techniques in terms of design. But what is this all for? And I think while we continue to talk about statistics through the next 1.5 to 2 hours, just to remind ourselves, why are we doing all of this, right? And I started this presentation to say that there is a huge burden of disease, which is increasing. And that is really the primary reason why we are all involved in oncology and oncology research. But, at the end of the day, there is a patient. And sometimes I always say to data managers and that, don't forget that there is a person behind all that data and numbers. And I'll share, a recently taken picture in our hospital for a child who's 7-year-old, did not want to celebrate his birthday when he was here, very upset. And, everybody's trying to cheer him up and coax him and say, happy birthday. And finally, smiled at the end of all of it and said, thank you very much. And, when he got that small gift and gesture, and very happy that he was treated well. So at the end of the day, what we're doing is for the patients and the future patients who are going to be afflicted by this disease. I would like to say thank you to all of you out there who are doing an enormous amount of contribution, because sometimes behind the data and the analysis, we may not realize our contributions. I think the patients have benefited enormously, as I said, over the last 2-3 decades because of the research that has happened. And I'm sure going forward, all our work in terms of data and statistics will help the future patients as well. So with that, thank you very much. Thank you to Algorix. Thank you, Nithiya, for inviting me. And all the best for this webinar, but also the series that I hope this will create called Statistics in Oncology.
Thank you, Mr. Suresh.